Hi, my name is Karen Black, and I'm a doctoral student at the University of Louisville, a psychiatric nurse practitioner, and I'm doing the project for my DNP degree. I was implementing universal suicide risk screening of adolescents in the emergency department. So I'm making this recording for those of you that did not get to meet with me personally, and in hopes that this will help answer any of the questions you may have. But at the end of the day, if you still have questions, please feel free to call me. I've got my phone number included at the end of the slide presentation, where you can write it down, and I'm perfectly willing and would be available. If not available, I will call you back to answer any questions. So um, let's get started. Um, I wanted to show you my picture so that when I come into the ER, I'll be making some periodic visits there while we're doing this screening, that you'll be able to recognize me and know who I am. So that's my mug, and we'll move on from here. Now, I know that you, as nurses, and many of you as parents, understand the problem of teen suicide. We're hearing more and more about it in the news lately. Um, it is devastating to families, and so I know, without ever even giving you this information, that you're very well aware and that this is a serious problem. Actually, the statistics on this, and the sources that I have cited here are from 2016, but it still remains in 2019 the second leading cause of death in teens age 15 to 19. That's a national statistic, and it's also a Kentucky statistic. We're right up there with the nationals. Suicides have been increasing over the past few years. In the past 15 years, between 1999 and 2014, suicide in females aged 10 to 14 increased by 200%, and in males by 37%. So it's on the rise. I have some of my own speculations about why that is. Not founded by research, but I'm sure that you all do too. And we know that suicide affects all races and socioeconomic groups. That's a given. So we know that the statistics show us that 39% of girls and almost 21% of boys felt sad or hopeless almost every day of the week for 2 weeks in a row. This was a Center for Disease Control study that was done in 2016 of youth risk behavior, kids in high school, grades 9 through 12. And these are their findings. That's a huge number of kids that feel sad or hopeless, and we know that that puts them at higher risk. In that same study, they found that 17% of girls and about 10% of boys had actually a planned attempt. They had a plan. Having a plan is one of the highest risk factors for suicide. 10.6% of girls and 5% of boys had actually attempted suicide. Now, when we think about this, this is 1 in 10 girls and 1 in 20 boys have actually attempted. So those are very sobering statistics. So how should we attack this problem? Well, we need to screen in order to prevent. We've got to screen for risk in order to detect it. And unfortunately, there's no standardization in process of, of when or how or where to screen. Nationwide, it's kind of all over the place. There are some schools that may screen kids for suicide risk, but those screenings may not be accurate, depending on what kinds of screenings they do and how well trained their personnel are. And schools don't always have access or the processes in place for subsequent referrals or treatment for students who do screen positive. So, they screen positive and, like, then what do you do? It's not always very clear. So a logical place to provide screening would seem to be in the primary care visits. But actually, and that's good, and we do that, but that's usually once a year, okay? And we know from Brito's study that approximately a third of all adolescents actually use the ED as their primary care source. They don't go to a primary care doctor. When they get sick or injured, they go to the emergency department. And adolescents are more likely to use the ED for acute conditions that could also be masking their feelings of depression and suicidal ideation. We know that Wilson and Klein reported that adolescents who use the ED as their primary source of health care also have a higher incidence of alcohol abuse and depression, which are known factors for suicide. So, screenings have increased, that have increased over the years, have definitely detected more suicide risk. So this one study is screening increased from 26 to 84% of kids. They almost doubled the amount of kids that they found were at risk for suicide. So why screen in the ED? Well, we know that a couple of studies found that 53% of the kids that screened positive for suicide risk did not come to the ER with suicide-related complaints. 19% of adolescents who screen positive presented to the ER with non-psychiatric complaints in another study, and over 35% of kids that presented with non-psychiatric and psychiatric complaints other than suicide ideation behavior came in with non-psychiatric and other psychiatric complaints, but still screened positive for suicide. So we know that somatic symptoms, particularly like headache, GI distress is a real big one, where kids internalize their feelings, and kids don't understand their feelings and can't sort out their feelings in the same way that adults do. They do not exhibit depression in the same way that adults do. They can present with irritability or behavior problems. They can present with physical complaints like headache and GI problems and those kinds of things. So we have to look beyond that when we see adolescents with these types of behaviors or complaints. There are suicide risk factors such as personal mental health problems like depression or bipolar disorder or substance abuse, being bullied, panic attacks, pathological internet use, and there are also some fixed risk factors such as family history, LGBTQ teens, those who've been physically or sexually abused or have parents with problems with mental health, and these do increase their risk. But lack of these risk factors, it's very important to note that not having any of these risk factors does not make the adolescent safe from suicide. And that's a very important point to remember. Now, as far as expert opinions go, the American Academy of Pediatrics does recognize the importance of universal screening, which they suggest be done by the primary care provider. And I think most primary care providers do this. But as I said, kids are sometimes only see their PCP once a year, and some of them don't use a PCP at all but go to the emergency room, a full third, according to the one study. The National Action Alliance for Suicide Prevention has as one of its goals to do universal screening with validated instruments that were specifically designed for these youths. So that's an important point too. Not just any old suicide screening tool is the best tool for these kids, and that's extremely important. Also, not all of these tools are user-friendly for the nurse, and if it's not user-friendly for the nurse, then it's not going to be any good. We've got to think about things that aren't labor-intensive and yet are still validated and specific for these kids. And lastly, but not least, the Joint Commission recommends universal screening in non-acute and acute care settings for all patients. So I think eventually we're going to see this being enforced as one of the, commandments of the Joint Commission. They did a database in 2016 of sentinel events and found that there were over 1,000 suicides between 2010 and 2014 that occurred in patients who were inpatients and in patients who had been discharged 72 hours or less. And that included discharge from the ED. So they found that the root cause analysis for these sentinel events were an inadequate psych assessment. So it means all the more important that we screen these kids. We screen everybody, but we need to start with our kids. Save our kids. So this was the question I asked for my project. It's how does universal screening among the adolescents presenting to the ER compare to selective screening for suicide risk in adolescents at risk for suicide, and identifying the adolescents at risk for suicide? Because normally what most places do now is they only screen for that if the patient gives them some kind of hint that there's trouble brewing, or they're depressed, or they come in with a suicide or a psychiatric related complaint. Now, looking at the literature, it's real important to note this top point. People will ask, and even educated, well-informed people, people in medical health, the medical field and mental health care field will ask me, if you ask a kid about suicide, aren't you going to put that thought into their head, plant that thought into their head? No, absolutely not is the answer. There's no data whatsoever in the literature to support that asking about suicide precipitates the behavior, even in kids that are high risk. Now, what I think some people get confused is that suicide can be somewhat contagious. In a cluster of kids, if one commits suicide, there is a higher risk for those in that cluster or that group to commit suicide. But not asking about it, not asking a kid about it, absolutely not. And all the more reason to screen kids who've had friends who've committed suicide, because their risk is increased. So we know that screening actually may provide a beneficial effect. Gould found that kids that were asked about suicide risk actually lowered their distress scores. They felt relieved. They felt like somebody cared enough to ask, and they kind of got it off their chest. So it can actually reduce stress in kids. We know that from many studies that adolescents and parents both overwhelmingly support suicide screening. And we know that a lot of kids that visit the ED complain of medical surgical complaints who will screen positive, and we would not have detected those kids if we had not asked. So how we're going to do this project of mine is, and hopefully that you all will continue this when I leave, because that's my passion, is that all kids that come into the ED between the ages 13 and 19 who present with non-psychiatric complaints will be screened. And the kids that will be excluded will be obviously those who can't speak English and may not understand what we're asking them. Kids that are cognitively challenged, have mental disabilities, and obviously those who are medically unstable are just going to be, we're not going to do this because their medical status is more important. No consent is required because it's going to be part of your nursing assessment, and the nurse is going to complete the Ask Suicide Screening questionnaire, either in triage or the exam room while the kid's waiting to be seen. But the most important thing is without the parent present. The parent cannot be there, and there'll be some helpful hints in your toolkit that I'm going to leave with you in the ER of how to talk with parents. Most parents don't mind, but it's like other things that we ask kids without the mom or the dad around. This is one of those, issues. I used to be an ER nurse, so I fully appreciate the kinds of questions that we ask our kids, in private. And this is one of those, because they will disclose it to you, but they won't disclose it to you with mom or dad in the room. If they come out positive, of course, we're going to bring the parent in and involve them, but just for the screening, we want to exclude the parent. So the nurse, you're going to score the questionnaire, and I'll go over that. It's pretty easy. If the kid scores positive, you'll let the ED doc know, and the ED doc is going to do another assessment of what's called a brief suicide safety assessment, where he or she will ask a few more in-depth questions and then determine the disposition of the patient from that point. So this is the 4 questions. There's only 4 questions in this screening. I wanted to make it user-friendly. I know, having worked in the ER, what organized chaos the ER is and how crazy it can get. We don't want to burden you. We want to do this and be effective in finding our kids, but we also want you to, be able to use it, and you're not going to use it if it's a 22 questionnaire. So that's kind of, ridiculous. And this is a very good tool. The questions are, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? Now, if they answer yes to that, you want to ask how they tried, and when was that, and how they tried. Okay? Any of those that the patient answers yes, or if they refuse to answer any of those questions, is considered a positive screen. If you get a positive screen, then you're going to ask a 5th and final question. Are you having thoughts of killing yourself right now? And that's going to determine the acuity of the risk and let the physician know what that acuity is. If they answer no, well, then they're considered a non-acute positive screen. And then the physician will do that brief suicide safety assessment. If they answer yes, having thoughts of killing yourself right now, well, then obviously that's an acute positive screen that requires an immediate full psychiatric evaluation by a mental health care professional. And you don't want to leave that patient alone then. You want to take anything dangerous out of the room, just as you would anyone else who's contemplating suicide. And then I've also included some demographic data for the purposes of my study. So this is a visual of what I just talked about, and it gives you a little algorithm. At the top is, the ASQ, the Ask Suicide Questions. If it's negative, then it's treatment as usual. If it's positive, then you ask question number 5. If question number 5 is yes, that's a full psych consult immediately and keep the patient safe. If it's question 5 is no, then the physician does the brief suicide safety assessment. If that turns out to be negative, then it's treatment as usual with mental health service referral for the patient to get treated for their obvious depression and non-acute suicide risk. If the physician thinks that brief suicide assessment is positive, then he or she is going to again ask for a full consult. Okay, so these are some of my measurements. As far as the demographics go, I would want you to, on the back side of the questionnaire, you'll see that there's a place to write down the patient's age in years, not birth date. We don't want any identifying information, just age in years, like 13, 14, 16, etc. Race or ethnicity, their chief complaint, what did they present to the ER with? Was it a stomach ache, was it, sprained ankle, laceration, whatever. And then what their gender is. So this data is all going to be non-identifiable. I'm going to come in periodically and I'll leave a box with you all where you can just slide the questionnaires into that box when you're finished. And I will be collecting that to collect my data. Obviously, you'll have to chart in the chart somewhere that a suicide screening was performed and what the results of that were. And this has all been approved by U of L's Internal Review Board and Catholic Health Initiatives, IRB as well. And then I'm going to look at some statistics and see if you did increase the number of kids that were identified at risk after initiating this compared with a time period before this. And I'll do a poster, a written report of the findings. I'll share that with all of you all so that you will know, how it turned out. So if you have any questions, please call me. Here's my number, 502-338-7417. If I don't answer, I will get back to you. Just let me know who you are and that you're working in the ED and you have a question, and I'll be happy to call you back. I know that you all have to agree this is a huge problem in our society right now, and we need to take steps. So I think I'm so happy that you're going to be doing this, and I think we need to be doing this everywhere. So thank you very much for your patience and your time, and again, give me a call if you have any questions whatsoever. Thanks. Bye.